Hey everybody. Good afternoon. It's the afternoon here on the East Coast, but I know we have a lot of worldwide listeners, so good evening or good morning, wherever you're zooming in from today. I am discussing and dancing with Mark today, which is actually our first time discussing together, so super looking forward to this. We've been collaborating on a teaching thread on myocarditis behind the scenes over the past couple of weeks. It's been a ton of fun. And the other reason today's super exciting is we actually have a first-time case presenter from Minahil. And Minahil, would you mind unmuting and just saying hi and telling us a little bit about yourself?
Yeah, sure. Hello, good afternoon, CP Solver members. I'm so glad to be here. I am an international medical graduate from Pakistan and I am watching this VMR since January. Always want to present a case and finally I got the opportunity today and I'm very much excited for today's VMR.
Oh my gosh, thanks again for being here. It's very nice to meet you. And Mark, any like pre-start words from yourself? How have you been?
I've been well. I mean, I couldn't be happier. I'm eating a nice parfait right now. I have some blackberries, blueberries, some honey, some yogurt. So I'm getting my brain prepared for this awesome case.
That's amazing. I think that may be the first parfait consumed on VMR. I don't know of any, and I go back to like the first 100 VMRs. But do you want to open up the whiteboard and we can go ahead and get started? Awesome. Thanks so much. All right, let's take it away.
Okay, so this is the story of a 46-year-old male being seen in the emergency department in a confused state. The patient was accompanied by his wife. The history was obtained from her as he was confused and not oriented. She explained that he just was not himself this morning. He seemed confused, could not grab hold of his thoughts, and his hands were shaking as if he was trying to catch something invisible. Then her concerns further deepened as she recounted how he suddenly felt this morning. His whole body was shaking uncontrollably for a minute, followed by an accident where he wet himself. His wife also reported a dry cough for the past week. His wife was asked about myalgia, nausea, vomiting, and diarrhea, and she denied all of them. Other details were not significant, so I will leave them out.
Wow, this is a really interesting start. Um, how do you want to do it, Mark? Do you want to start?
Yeah, honestly, Andrew, I love your approach to confusion. If you wanted to start with that, and I can layer on the kind of following symptoms if you want to do that.
Yeah, for sure. So, what we have here is altered mental status and a pretty young patient. So automatically that's pretty concerning off the bat. What we're going to pair the altered mental status with is it's going to sound like seizure. It sounds like we have a loss of consciousness event accompanied by diffuse body shaking. And perhaps what we're even seeing afterward is just postictal confusion. And perhaps that's what's going on. But I can just start with the generic altered mental status approach before we kind of call this like a postictal kind of state from a seizure. So my approach to altered mental status is very thorough. It as you get more labs and as you get more data, you can cross off a lot of the things on this list. But the mnemonic I use for altered mental status is MINT. And before that, I think of some of the life-threatening causes and workup you can do for acute altered mental status. And the mnemonic I use for that is SCAN. So as this patient's coming into the hospital, I want to know S, is there a sugar? Is this patient hypoglycemic for any reason, especially if they're diabetic? C, I think CT head. Is this a patient who could have a large intracranial lesion, whether that be a bleed or a mass or an infection? A is ABG/VBG. You don't need an ABG to figure out if a patient's retaining carbon dioxide. You could get that through a VBG too, but in the mnemonic, it's A for ABG. So is this patient at risk for CO2 retention? Like, do they have a COPD history? Do they have a brewing pneumonia and maybe are tiring out? And then N is for narcotics. Does patients have any exposure to opioids? This is particularly for the hospitalized patients who are getting a lot of opioids. So those are some things that we could kind of rule out. The sugar, I think, is going to be particularly important if we're thinking along the lines of seizure in this patient to make sure they're not hypoglycemic causing this. And then CT head may bear fruits if this is a seizure, as if we see a large lesion that could certainly be triggering a seizure. And I think probably Mark can talk about the differential for seizure if we want to go down that road. But going back to the MINT mnemonic, I'll just give broad strokes. At metabolic, you could just think of all the things on the metabolic fishbone diagram that can cause altered mental status, along with a couple of additions that I add. So on the basic metabolic panel, you can think of sodium, you can think of BUN being very high, uremia, and then some of the additional ones are like ammonia. I kind of throw in urinary retention for all elderly people, just things that kind of put in that bucket. Eye infection. This is going to be a little bit more interesting in a patient like this. You know, in younger people, you generally need to have some sort of like CNS infection causing this degree of confusion. But if you're older, insults outside of the brain can cause you to be pretty confused. But in a young person like this, we're thinking inside the brain if there is an infection. N is for neurologic, and I won't go there. I split that into pre, inter, and post brain. And then T is for toxic exposures or withdrawal syndromes. So just getting a feel for, do we know, is this patient on like chronic benzodiazepines? Do they have chronic alcohol use? Things like this. So very, very broad. We can go from, I think, kind of the seizure pathway if you want to go down that way. Mark, I'm very curious for your thoughts.
Yeah, no, that was incredible, incredibly thorough. And luckily, honestly, like my approach to seizures is very similar to my approach to altered mental status. I use this NMINT or MIST in terms of like metabolic, infectious, structural, and toxin. And I would say that, you know, not every patient with just, you know, altered mental status or confusion needs a CT head, but someone that, especially a young patient that we're concerned for a possible seizure, and especially if this is a first-time seizure, we're going to get more history to see if there's a history of seizures or epilepsy, and then we can kind of think of like triggers for seizures if this is seizures. But I would definitely get a CT head of this patient because, you know, space occupying lesions like tumors or abscesses or, you know, cerebral venous sinus thrombosis, these kind of things can definitely trigger a seizure. The only other thing I'll add is that, you know, in the background, we have this week of persistent dry cough. You know, we're not really getting any other symptoms, but, you know, are we dealing with a pulmonary CNS, you know, syndrome or disease? I think I won't really go into that differential right now because I definitely gonna want some chest imaging to see if, you know, is there an abscess or cavitary lung lesion, and then, you know, the differential will kind of narrow. But, or is it something like, you know, this patient had a viral infection or influenza that predisposes to like encephalitis? So I think that, just like Andrew said, I think the point of care glucose and the CT head are going to be really important in this case. And then I'm just very curious what that kind of dry cough is in the background. And I think a chest x-ray will be really helpful. But luckily, it seems like the patient's not, you know, seizing currently in the moment. Or, you know, we can always chat about the management of like seizures in the moment or status epilepticus. But yeah, I'm very interested to hear this patient's background if this happened before and kind of some exam and basic labs.
Amazing. All right, aliquot number 2, Anahil.
Yeah, sure. Awesome discussion. So for the next aliquot, his past medical history was significant for pulmonary tuberculosis back in 2010, which was treated and resolved. He used to work as a radiologist technician for 21 years and quit his job 2 months ago. He has no recent travel history and lives alone with his wife. He smoked 1 pack per day for the last 25 years, does not use any illicit drug, and does not consume alcohol, not on any medications, none on allergies, and no significant family history. Coming towards initial assessment and examination, in his vitals, his BP was 110/70, temperature was 100 Fahrenheit, heart rate was 65, respiratory rate was 20, and SpO2 was 95% on room air. In general appearance, he looked pale, confused, and during the examination, we also noted fly-catching tremors, and there was no evidence of tongue biting. Going towards the neurological examination, he was confused, not oriented to time, place, or person. His GCS was 12 out of 15. So to elaborate it further, he was opening his eyes to verbal command, and verbal response was confused. His motor response was localized to pain. Therefore, his GCS was E3, E4, and 5. In his neck was stiff, and there was hyperreflexia in knee and ankle joint. His motor strength was normal. Sensations were intact. We also did a fundoscopy, which was normal. Then coming towards the respiratory examination, auscultation revealed respiratory trackers bilaterally. Chest appearance was normal and no abnormalities were noted on palpation. Other systems exam findings were unremarkable.
Wow, this got spicy very quickly. Mark, do you want to start this one off?
Yeah, sure. So I'll kind of talk a little bit about the background data and maybe go into some of the exam findings. So yeah, we have a prominent history of pulmonary tuberculosis. I'd be very curious if, that was treated and how the patient has been doing over time. Kind of get into the lung brain syndromes. Tuberculosis loves to go to the brain. It can do a few things to the brain. It could cause like tuberculomas, which can essentially just form masses in the brain. That definitely could be a seizure focus for sure. It also has a propensity to cause basilar meningitis. And usually if it's causing meningitis, usually the MRI will be positive. So, down the line, if we get an MRI, I'd be very curious if there's any enhancement in that area for, thinking about tuberculosis. And then, TB can also affect the spine as well. So, TB can do a lot along the neuroaxis. So I'm definitely tracking that. I think it really just expands the differential to this point, doesn't really narrow it to, obviously just tuberculosis. And then other things, the health-related behaviors. This patient does have a significant smoking history, 25 years. They are a little young. I'm definitely tracking that. Are they at risk of lung cancer? And now they have, metastatic lung cancer to the brain that's causing now, a focus for seizures or CNS kind of symptoms. I think, that's definitely possible. So those are kind of the main things on the background data that I'm tracking. Most notably, this patient has no history of other, CNS disorders or seizures. So this is totally new for this patient. I think further kind of emphasizing that we definitely need some neuroimaging here. Just kind of my thoughts on the background data. Andrew, we can kind of maybe go back and forth on exam, but I'm curious about your initial thoughts on the exam.
Yeah, totally with you. And the only addition I have for the past medical, just kind of talking about the TB a little bit more, is I'm just thinking of all these CPS exercises where the diagnosis ends up being TB and how kind of rocky of a course it is to get to that diagnosis. And I don't know, I'm kind of getting the flavor here that this is a very acute presentation, like got unwell a week ago and is just like progressively deteriorating. And this guy's like drooling on exam, not oriented at all. Like this is an awful, awful exam. So I guess he could have like a focus of TB kind of causing like recurrent seizure, and that's why his mental status is so bad. But just the tempo of this seems so fast, it does make me a little bit skeptical that maybe that's a red herring. But certainly we're going to be tracking that, like you said. And the other thing about the exam that kind of struck me is I think we heard something about kind of a prominent diffuse tremor going on. And Manel, I don't know if you want to drop in the chat kind of how you characterize that. I didn't catch how you characterized it, but if I see like a diffuse tremor that's acute like this and someone who's clearly very ill, I'm kind of wondering if they have something on labs that's gonna explain that. Fly catching tremor. I'm going to be honest, I've never heard of that before. But if I see a diffuse tremor in someone who's very sick, I'm wondering if they're like azotemic, like this guy like not been eating for a week and he's going to have like a BUN that's like 100, and that's why he's having kind of like uncontrolled tremor. Um, Basically, I pin in my head that on the metabolic system, just because if you're going to have a diffuse kind of body tremor, it's probably not going to come from the brain like centrally at a tempo like this. This is very quickly. I'm thinking that maybe he's azotemic, or maybe the sodium is going to be like 105. I've seen hyponatremia, I've seen uremia cause tremor like this. Something you can see with that is multidirectional nystagmus. If you look at the eyes, their eyes will be bouncing kind of all over the place. But I'm just kind of wondering what we're going to see on labs with that tremor. But no, I'm with you. I think head imaging, LP, this guy, see what's going on in the CSF, test for infection, and go from there. I think just like big picture, I'm kind of framing this as a guy who's at high risk of an acute infection that's leading to like CNS infection, meningitis, and then perhaps some like metabolic abnormalities that are causing the tremor. But we'll see how the labs look.
Andrew, can I mention one thing? I think it's always important too when we do these like wonderful diagnostic reasoning exercises, also to think like management reasoning and like what you would do in real life, and that's something I definitely enjoy. Um, like I wonder if can we almost frame this before we have the labs as like a meningoencephalitis in terms of the syndrome. I mean, it sounds like if I heard him correctly or heard you correctly, the patient has a stick neck. They're stick neck. They're very confused. They have a temperature of 100. And I'm just thinking in real life, I think this patient, if we have access to a CT scanner, we need a stat CT head before we do the lumbar puncture, just to make sure there's no like space occupying lesion, which is totally plausible here, before we stick a needle in the patient's back to prevent brain herniation. But I don't know about you, Andrew, but I definitely would be empirically treating this patient for meningoencephalitis. Um,
Yeah, I don't do that every day, so I'll try and give my empiric coverage. What age? So you start with vancomycin for like staph coverage, ceftriaxone as CNS penetration, right? So we're gonna add that on, and then there's that like plus or minus the listeria coverage above age 50, 55, one of these. Okay. So we're thinking of that. And then of course, like if it's going to be like mycobacterial, it's a whole other like ballpark, but that sounds good. Yeah, I'm down.
Totally. And I think the only other thing I would add is I feel like I usually have a very low threshold to add acyclovir to, in terms of, it probably wouldn't make the patient this sick. And then also probably giving steroids too, just for strep pneumomeningitis, kind of like the mortality benefit of that before giving the antimicrobials. But yeah, this patient's really sick. I'm very curious what happens next.
It feels like such a privilege to be able to see you guys dissecting the case and adding the little pearls. So I'm diving into the third report. A panel of tests returned revealing his internal status. His hemoglobin was robust 13.8. WBC is slightly elevated at 11.5 with predominance of lymphocyte cell line. Platelets were at 280. ESR was 17. LFTs were slightly deranged with AST 37, ALT 42. Serum sodium was 140. Potassium was 4. Creatinine was 100 micromole. Glucose was 80. Calcium was 88.9. Magnesium was 1.5. Lactate was 1. And then we did a brain CT scan and we observed diffuse meningeal enhancement and periventricular hypodensities. After that, we did a lumbar puncture. So analysis shows opening pressure of 10 milliliter of mercury. Appearance was normal. And WBCs were 370. Polymorphonuclear cells were 25%. Monocytes were 48%. Lymphocytes were 35%. Glucose was 67. Protein was 233. And RBCs were 0.
Ooh, well, um, I I think just like type 1 thinking responses to this, Mark. I'm kind of getting flavor of viral infection potentially with kind of just like the tempo, this like cough preceding all of this, the lymphocytes in the CSF, the diff on the blood count is lymphocyte predominant. I don't know. What do you think?
No, I'm right there with you. I think we definitely have our pivot point here. I think, and if I'm just reading the CSF profile appropriately, it seems like we have like a lymphocyte slash monocyte kind of predominant CSF profile. Is that correct? And with the glucose being high, or I'm sorry, the glucose being normal and the protein being high. So no, I mean, Andrew, I'm right there with you. I think, and I don't know if we want to talk about now, just kind of like our approach to a lymphocyte pleocytosis in the CSF. I think, viruses definitely being the most common. And the one that we can act on really is, like I mentioned, HSV2 encephalitis, which can be pretty devastating. I've seen a few cases in residency. And I think this is where the CT scan will be helpful. Where was the hypodensities on the CT scan? I know there's bilateral hypodensities. Where in the brain?
So I don't have that particular information, like specific where they are.
Gotcha. No worries at all. No worries at all. Yeah, I kind of recently learned after my global health trip in Botswana, we had a few patients with the HSV encephalitis. So I did went into deep reading on it. And, usually, especially after a few days of the course, the CT scan and definitely the MRI is almost like 98% sensitive. After about 2 days of the illness, they'll show some sort of signal enhancement in the brain. Usually, classically, we learn in medical school, that's the bilateral temporal lobes. And the clinical consequence of that is the temporal lobes are very epileptogenic. So a lot of patients with HSV encephalitis do present with seizures. So this actually would fit pretty nicely. If I'm remembering correctly from my reading, it's usually unilateral enhancement in the brain. And I think if it's bilateral, you might think of some other cause of encephalitis, but I don't think that's a rule. So HSV encephalitis would fit well. I think will be classically learned with like a lot of RBCs in the lumbar puncture. I don't think that's super sensitive. I think it's nice when it's there, but it's not really a sensitive finding. So I think HSV encephalitis definitely could be at play here, but all the other viral encephalitis like enterovirus, HIV, West Nile, and then moving more towards like other etiologies. We've already mentioned tuberculosis, but Andrew, I love your point about the time course. This is like way too quick for tuberculosis, usually more of like a subacute course. But then kind of thinking about like, endemic mycoses and then other kind of like atypical bacteria like Legionella, that's with the preceding cough and maybe, pulmonary syndrome that the patient had. And then also Listeria can look like this too. So yeah, I think I'm curious what you think, Andrew.
Yeah, totally. I agree with all of that. Just a smattering of kind of thoughts that came up as you were discussing. Yeah, I was reading about intracranial hemorrhage the other day, specifically like atraumatic hemorrhages and some of the infections that can do this. HSV has this like hemorrhagic component where the classical textbook picture is they come to the hospital already bad, like they're altered and all this stuff, and then you treat them, but then they like get worse. So if this patient like were to deteriorate in the hospital and develop like RBCs in the CSF, and if you scan them like a non-con and you start seeing hemorrhage in the temporal lobes, that would be like seems very, very, very specific for HSV. So that is curious, and I'm kind of curious about characterizing the scan more, like you're saying. Other than that, I was just gonna throw in on ID consults. I saw EBV cause a pretty dramatic meningoencephalitis with altered mental status like this. I've been surprised by that. This guy doesn't have the kind of the lab signature for that. Often you get a mild like hepatitis with EBV, and also the preceding history is more like sore throats, like lymphadenopathy, kind of that like mono syndrome. But it seems like you were saying this is kind of more like a viral respiratory type syndrome. So it's probably not going to be that. We saw VZV the other day on VMR2. That was pretty surprising. That was causing like a transverse myelitis, but apparently VZV can kind of do anything. So yeah, I think going down kind of this testing pathway, Mark, and coming from a resource limited setting, when you're in Botswana, I was wondering kind of like what tests were available to you over there, just kind of out of curiosity. And if we didn't have these tests available, perhaps this would just be kind of like an acyclovir, kind of like empiric treatment course. And then I guess we'd just have to consider like fungal coverage pretty strongly, since it seems those the main kind of like competing differential. We're kind of not thinking this is bacterial. I'm just curious, kind of what your thought process would be.
Yeah, we had great CSF testing when during my time at Botswana, because they could send biofires off of the CSF. So we got, pretty quick answers to viral causes of encephalitis. I think one of the most highest yield tests is a HSV PCR in the CSF, which is almost 90, it's like almost 100% sensitive. It's a very good test, especially like I mentioned, a couple days after the illness started, which it sounds like, we're kind of at that point. So I think an HSV PCR is very high yield here, and I definitely would keep this patient on acyclovir for sure. And then kind of practical tips with acyclovir. It's always good to continue like maintenance, have them on maintenance fluids to prevent the crystal nephropathy that they can develop. Acyclovir can kind of crystallize in the tubules. So you want to keep them well hydrated. So, but yeah, I think, HSV is probably where I'm leaning right here. Yeah.
Okay, I had one other thought that came up because I just saw on the whiteboard periventricular hypodensities. That's what I thought I heard, something about periventricular. I don't know why my brain goes to outside of TB that can land kind of in the ventricles and kind of clog that whole system up and cause like hydrocephalus. I'm also thinking of these cases of neurocysticercosis. There was one that was here at Yale, a morning report, and then the other day there was another Yale morning reports. Uh, uh, Clara brought it here. I forget her name. She brought a case of neurocysticercosis causing seizures, but I don't think the story really fits for that here. Can cause seizures, very, very common cause of seizure. I believe the worldwide most common cause of seizure, actually. But I think this whole like preceding syndrome doesn't fit. But I have seen neurocysticercosis kind of land like I believe in the periventricular region and cause of being a nidus for seizure, which I guess we haven't really said. The labs never bore fruit with the diffuse tremor. So why is he having diffuse tremor if it's not metabolic in origin? So yeah, is this person having like status epilepticus? I'm now, as I say this out loud, maybe we should have this person on continuous EEG to figure out if they're in status and that's causing kind of this diffuse tremor that we don't yet have an explanation for. And we may be thinking about anti-seizure treatment at that time. But yeah, I'm kind of curious what's going to come next. It's very hard to predict, but hopefully we're in the right ballpark.
Yeah, I'm kind of going back to my neuroanatomy too, because like periventricular, I guess, is there also like involvement in the basal ganglia? And I think what's tough is that there's like very, well described associations with like certain bugs in certain areas of the brain. The issue is a lot of them are very insensitive besides HSV encephalitis. So for instance, like West Nile classically involves like the deep gray matter. Same thing with like, rabies can sometimes affect the deep gray matter. Like you mentioned, like VZV can also affect the temporal lobe, like varicella, like the cerebellum. The issue is I think a lot of these are just very insensitive. It's nice when they're there, but, and I'm also wondering like if there's basoganglia involvement, is this patient having almost like a Parkinson's type of tremor? Because sometimes that can happen with like lesions in like the basal ganglia. So, but yeah, I agree with you. Kind of assume it's probably likely the patient is seizing, and an EEG would be like really helpful.
Awesome. All you, Nahil. This is fascinating. I don't know what's coming next.
I'm loving your guys' discussions. So at this point, we started the treatment with anti-seizure medication. So as a radiologist technician, he was at a risk of occupational hazards. So before we get the CSF analysis, we started the patient on corticosteroids to combat any insidious inflammation from suspected radiation exposure. But despite this, his condition took a turn and like his fever persisted and her breaths become shallow and more rapid. His oxygen saturation dropped down to 90% on room air. And then we conducted arterial blood gases, so which revealed the results as pH was 7.39, PCO2 was 43, PO2 was 81, and his bicarbonate was 22. We also did a CT scan of the chest. So it revealed a multifocal bilateral ground glass capacities. And there was also consolidation, fibrosis, and upper lobe scarring. So before you guys take over, I want to mention that in the next report, I will also reveal a missing piece information that will lead to the final diagnosis.
right. Mark, I know the chest CT is one of your favorite things, so I won't touch that. I'll just say I think the ABG is very curious. First of all, you don't need the ABG to confirm he's hypoxemic, like SpO2 of 90% is abnormal. If you want to be conservative about it, SpO2 less than 94% is abnormal for needing a PaO2 of 60. Um, but it's curious. I feel like it's out of proportion. His mental status and this clinical deterioration is out of proportion to the gas we just got and kind of like how he looked before. Like I see that there's stuff going on in the lungs and perhaps that changes the calculus of the organism we're talking about. But I feel like the most devastation is happening in the brain. Like if he were much more hypoxemic, if he were retaining CO2, kind of suggesting he's truly tiring out from something, then I would kind of think about the lungs a little bit more. I think that we are going to have to use the lungs to kind of influence our DDX, but I'm getting the sense that devastation is really happening in the brain, and that's why he's like not protecting his airway and why he's getting intubated right now. It sounds like he looks bad, but I'm not convinced it's from the lungs quite yet. I just think that that is a signature of something that's perhaps causing more damage in the brain. I don't know. The only organism that's kind of coming to mind, Mark, is like crypto, kind of like lung brain, for lymphocytic predominant stuff. But again, I think the tempo for that is a little quick. But yeah, I'm curious for your chest CT dissection.
Yeah, I definitely love my GGOs for sure. Yeah, that no, crypto is a very interesting thought, and that made me. I was going to mention that I think this patient definitely needs an HIV test. I think that really helps stratify causes of meningoencephalitis too. Like, are they immunocompetent or immunocompromised? I'd be very interested in a HIV test because certainly too, if they're if they have HIV, then crypto would be a nice diagnosis here. Typically, the opening pressure in crypto is going to be, a little higher. It tends to cause a lot of like hydrocephalus and increased opening pressure. And the lung findings typically depends on if it's cryptococcus like neoformis or gaddii, but usually tends to be more like abscesses and cavitary lung lesions. But definitely could be GGOs as well. And practically speaking, I wonder if the GGOs could be a result of like an aspiration pneumonitis or an aspiration pneumonia when the patient had a possible seizure. So that's definitely possible. But if it's one of the primary problems, especially with this preceding dry cough that the patient have, I think viral infections leading to like a lung and brain syndrome are definitely possible. And then I'll keep bringing up, tuberculosis. I know the time course is quick. GGOs are pretty atypical for tuberculosis, but anytime lung brain with this history, I'm definitely thinking about TB. So I definitely think we should, test for TB. Testing for TB is very difficult. And I'll leave that for another time, but I definitely think this patient needs some sort of TB testing. And then in the right, depending on the, where you practice, endemic mycoses can do honestly exactly this. Histoplasmosis can do lung and brain stuff. Also like endocarditis, right? Like if endocarditis causes septic emboli to the lung and then to the brain, causing devastation to CNS as well. So yeah, this patient is very sick, and I'm very curious about like other CSF studies that were sent, and also in like tuberculosis testing and HIV testing. I think those are nocardia is also another one to think about with lung and brain stuff. But again, that's usually more of like lung abscess, brain abscess, not as much maybe like GGOs and periventricular hypodensity. So I also wonder if an MRI, the patient doesn't seem stable enough for an MRI at this point, but an MRI to better characterize what's going on in the CSF or in the CNS as well.
Yeah, so I guess to put our money down on things we want because it's really impossible to predict what this is gonna be. It sounds like we want kind of the biofire routine panel and before that HIV, but the biofire panel having HSV, VZV, EBV. We heard West Nile virus for kind of the tremor propensity, perhaps. And we have these like fungal studies we want, like a crag. We could get like the serum crag. Is there a CSF crag? I forget if there's a CSF crag. There is. Okay, CSF crag, serum crag. Doesn't seem in the right area for like histo, but global warming. So I don't know if histo is in this area. I'm pretty sure it's out there. And then I saw CMV in the chat too. We can throw that in there. Can cause ground glass. I think usually CMV illness that would be the severe, you have to be immunocompromised, but maybe this person is HIV positive, but even then, I'm not sure if that's kind of the right host for a CMV infection like this, but we can throw it on. PJP was put in the chat, not on any immunosuppression, but could have HIV. So certainly can contribute to that. And I'm not sure if PJP kind of causes the CNS type disease. I don't think so. At least I've never seen it. And then Pontiac fever, I believe that's Legionella. That's next to Sruti's comments. That certainly can cause lung devastation and like CNS stuff. Again, I'm not sold that the lung stuff is super bad. It kind of seems like this is more neurologic, and I kind of like that aspiration hypothesis, Mark. I'm kind of curious if that's actually what's going on. But what did I miss? What else should we send? That way we could say we sent all the things.
Yeah. I mean, toxo as well. Again, I think the HIV status is going to really help stratify this, but toxo can definitely affect those areas in the brain. And then in a patient with HIV can also cause a pneumonitis as well. So, and I really do like the Legionella. I think testing at least like a urine, Legionella, or I don't think I've ever tested for a Legionella in the CSF. I'm sure there's a way to do it. The urine Legionella is not perfect. It does miss some of the serovars, but and especially Legionella has this propensity in patients that smoke as well to cause a lot of devastation. So I think that's also, an interesting thing to test for. But yeah, what'd you guys test for?
Okay, so I love the discussion and you guys are thinking the same way we were thinking. At this point, I would like to share a missing piece of history that I held back initially, because that is how the story unfolded for us. So on the day one, his wife did not mention about his recent hobby of keeping and trading exotic birds, particularly parrots. Like his wife later on told us he had bought like 100 to 150 parrots, and he's keeping and taking care of those parrots by himself. And I remember going back a few days later to visit the patient history. That's when she was comfortable talking and shared recent hobby. And this information led us to run the test that finally revealed the culprit. So before I reveal the diagnosis, I want to ask you guys, like, what are your final thoughts now, and what should we check for now?
Wow, that's a unexpected turn. Uh, I'll just say the only bird association I have is chlamydia psittaci or psittacosis. Um, definitely the lung stuff that causes lung stuff. Can be confused with like hypersensitivity pneumonitis, given kind of, same exposure. There's this like disease, bird fanciers lung. You can get like hypersensitivity pneumonitis, but I think we'd be looking at a true infection here, since we have a meningoencephalitis in front of us. But doxycycline deficient state, I think now, Mark. I don't know, maybe this is throwing us off, but it is our penultimate aliquot. So what do you think?
Yeah, I think I also think a crypto as well, and histo, and in terms of bird stuff. I'm not too familiar with like the Chlamydophila psittaci causing a lot of CNS like devastation. That's definitely would be a knowledge gap for me. But I think this is a shout out to a serum crag. It's honestly one of the best infectious disease tests we have in medicine. It's like even for CNS disease, it's almost like 99% sensitive for like meningoencephalitis from crypto, and it comes back pretty fast in a lot of labs. So I think a crag is a very high yield test in this patient. And again, like histo, I don't think we're in the right area for histo, but like Andrew said, global warming. I feel like histo is kind of the great mimicker these days. So, and a urine histo is also and a serum histo is also great tests as well. So, yeah, I'm very curious what that next test is. Maybe it's going to be an HIV test also, and then that'll send us down another pathway. But yeah.
And Mark, what is the explanation behind crypto in the parrots? Is it the stool of the birds? I forget this. I can never keep this association straight.
I believe so. Because I think one of historically the big association was in like New York City with a lot of the like birds and like construction workers. Like that was one of the first. I think I'm remembering that from medical school. That's like one of those like history and medicine stories. So I think it's from the feces of birds. Again, like I'm not loving the GGO's periventricular normal opening pressure for crypto. Like, I think, crypto can do a lot of things, but I think those manifestations are pretty atypical, even though it's like lung CNS. But the crag is such a good test, so I would definitely want that.
Mark, Yaz in the chat, you could just tell she loves microbes. She's like, droopings and humidity, great starter for the fungus. Oh my gosh, that's so good. I'm never gonna forget that now. Oh, and then Adolfo said crypto lesion, the basal ganglia. Oh goodness. Okay, well, I'm gonna go with you all smart people. That sounds like a good place to put our final money down. But what did we look at, Vinahil?
Yeah, so like guys were thinking the same way with me. So like due to the suspicion of the parrots, at first we did a serology test for the chlamydia, and it's IgG compositive for chlamydia cytici, and we diagnosed the patient as psittacosis. We treated him with the doxycycline, IV 100 milligram BT, and like we give it for like 14 days, 2 weeks, and patient get improved with it.
Wow. Okay. Well, there's
Wow.
yeah, there CNS psittacosis. There it is, folks. Wow. Wow, wow, wow. I have nothing else to say.
Andrew, this was not on my radar. I feel like when I think of like Chlamydophila, I'm like, yeah, that's one of the atypicals that we're covering with Azithro or doxycycline for community-acquired pneumonia. I feel like I'm not giving it enough respect, honestly. I definitely need to do a lot of reading on psittacosis.
Yeah, what teaching do you have for us, Vanilla? If you brought any, because this is incredible. This is so rare. Unless if we're missing something. Yeah, what did you all learn from this case?
Yeah, so the main take-home points for me was like history is always a king. A good history helps us to connect the dots. Maybe initially patients or their family members, due to the stress, are not able to relieve the very important information, and like they might even not know that this is information for us to reveal the final diagnosis. So I always make sure after this to follow up visits, to give the follow-up visits to the patient or the attendants and ask about their history to get any more clues.
Yeah, it's so true. Yeah, humbling case. Kudos to the team for taking that history and finding this out. It's incredibly hard to treat. I guess probably impossible to treat without doxycycline. So I'm really glad that they did better. It sounds like he was pretty sick. Um, any final reflections, Mark, for teaching points?
Yeah, no, I can't wait to take a deep dive into CNS psittacosis. Yeah, I wonder if those like, I mean, GGOs are very non-specific, but could that point us more towards like an atypical infection and kind of trigger that, atypical bacteria that can do that, and then that would trigger, for me, I would have definitely just been looking at a lot of things online in terms of, what atypical bacteria can cause this kind of CNS syndrome. But no, a lot to learn from this case. Thanks for bringing it.
Yeah, and like I also love presenting my case with you guys first presentation, and thank you for all the discussions.
Yeah, of course, please come back. Please come back. We'll pass it off to Elena for teaching points. Thanks, Elena.
Hey, thanks everyone. Thanks, Minahil, for coming here and being such a fantastic case. I hope to see you back very soon. So in the beginning, Andrew shared a great approach to altered mental status with us that is actually twofold. So on the one hand, we have to look for the causes, and we usually use the MIST or MINT mnemonic. So that is metabolic, infections, neurological problems, or toxic. And as you can see, 75% of those are actually extracranial. So we have to be aware of that. But before we even start thinking of any causes of altered mental status, we should be able to manage those patients. And a great mnemonic to manage those patients is SCAN. So we look for sugar for any hypo or hyperglycemia. We get a CT scan, and in this case, it was very important because the patient also presented with seizures. So to look for any space occupying lesion is very important. We should get an ABG or a VBG, and we should watch out for narcotics. The patient also had like a 1 week history of dry cough. So at this point, we were thinking of palm and CNS syndromes. Those are infections that involve both the CNS as well as lungs. Examples can be nocardia, fungal infections, also thromboembolic events, for example, in the context of endocarditis. We should think of hypovirulent Klebsiella and mycobacteria. So the patient also had a past medical history of TB, and there's actually a variety of ways that tuberculosis can travel to the brain. So it can cause inflammation along the whole neural axis. Examples are TB, meningitis, or meningoencephalitis, tuberculoma, basilar meningitis, or abscesses. Again, going back to managing this patient, it's very important to start with empirical treatment right away. So we would give this patient Vanco for staph species coverage. We would give ceftriaxone, and in patients who are older than 50 years, we should also cover listeria with ampicillin. And we should also cover acyclovir. And Mark shared with us that it's very important to hydrate those patients because of the potential risk of crystal nephropathy. Because of the risk of strep pneumomeningitis, we should also give steroids. So the CSF that came back for this patient actually showed a mixed picture of lymphocytic and monocytic pleocytosis. And at this point, we prioritized viral infections, endemic mycoses, and atypical bacteria like Legionella or Listeria. Mark shared a lot of cool pearls with us about HSV encephalitis. And he mentioned that in the course of the disease, 90% get sensitive, there's a 90% sensitivity for MRI. And they usually present as unilateral temporal hypodensities. And this is an area of the brain that is actually very epileptogenic. Also, a hemorrhage can occur in these instances and can lead to deterioration even after the initiation of antiviral treatment. The case took an interesting twist in the end because we learned that there was actually relevant bird exposure. And infections that we associate with birds are cytocosis, crypto, and histo. Thank you so much.
Elena, that was amazing. So much. I feel like you captured the journey so perfectly. Thanks as always. And I actually did have one last residual question. Mark, we never tied up the tremor. Manahel, do you know what happened with that tremor? What was going on? Just out of curiosity, because now it's going to kill me if we don't have an answer. Maybe we don't have one.
We also did not get like any specific reason for that tremors, but that were like very specific tremors. For like fly catching, he was moving his fingers like this and this. So that was very different for me too. Like, but we did not find any specific reason for it. But it get resolved after this treatment.
I see. Thank you so much for letting us know that. Hope everyone has a great rest of the week. Thanks for coming.
See you guys.